Okay, so Q&A time. We have a lot of questions. So you want to, the last 5 or 10 are related to design and widgets. So you may want to go backwards. I've put it in the Google Doc. We're up to 64. If you want to go that way, all the way down.
So one of the questions was, what's the reason for always clasping the middle tooth as opposed to clasping the 6? And this is basic partial denture design, isn't it? You want an appliance that's stable. The most stable appliances are always got the anchorage in the middle with resistance through rest on either side. If you clasp the end tooth, you will always have a flipper effect from the front.
Yep.
Then you have to clasp an anterior tooth. And if you're trying to change the alignment of an anterior tooth, then you are only clasping a 6-year-old molar. But I'm also going to give you the literature of why we want to clasp primary teeth and not permanent teeth in upcoming lectures over the next couple of days. So everything that we do is literature-based, is evidence-based. So Lupita asked, where's the shelf to avoid the Brody bite? And I think I drew that in the design. And Jess asked, what's the difference between a hand clasp and a crozet clasp? A hand clasp is one where you have 2 wires that cross over and are soldered together. A crozet clasp is a continuous loop where you add a crescent. The answer to the question of which is better, and my answer to that is I've used both, and we don't use them anymore because we use the one that Enrico designed, which is a crozet clasp, welded, laser welded, and soldered. But they are fitted and adjusted the same way. So the question is, because the rate is different, upper expands 3 times faster than the lower. The question is, do we differentially treat? And the answer is, you can do whatever is easier for the child. Some kids find it easier to just start with the lower appliance. The lower appliance is easy usually to use. And we might do a few weeks of expanding just on the lower arch before you do the upper. But you have to bear in mind, there is no mechanism to help you manage a crossbite. But there are shelves in the upper appliance that allow you to manage a Brody bite. So my recommendation is you're welcome to start the lower a month or a few weeks before the upper, but no longer than that, I would recommend. We know the rate is different, but we've built in a shelf to allow maximum improvement on the maxilla as early as possible, but maintainable despite the discrepancy in the bite with the component, which is the shelf built in. I built a 2 millimeter shelf to allow for that difference. So Olivia asked if we could see the appliance that we used to intrude the 6, and we showed you that appliance already, the hang expansor. So that was already displayed in the PowerPoint. So do I recommend any basic orthodontic courses? Jasmine Green asked. I think if you're going to do any form of early intervention, you need to be trained in orthodontics. I think you need to have a good foundation, and there are many courses throughout the world, depending on where you live. All universities will hold continuing education training for general dentists who are interested in doing orthodontics. They're kind of long programs that run many years, and they are diploma type courses that are very comprehensive. So they're available in almost every major teaching university in the world. They're designed to help general dentists who have very poor understanding of orthodontics to have a reasonable level of competency and understanding in orthodontics. Alternatively, there are lots and lots of privately run courses by orthodontists who teach general dentists. In Australia, for example, the two prominent ones are Derek Mahoney's EODO course, excellent program that runs about 2 years, 2.5 years. And the one that I trained in was POS, which is Progressive Orthodontic Seminars, which is based in Las Vegas, and they run courses throughout the world for general dentists. Mine was one of the older courses that ran 2.5 years. And it was every 2 months was a 4-day week end of training for the 2.5 years. So you do need to really get your foundation right. And I do not recommend you do orthodontics unless you have training in orthodontics. And early intervention orthodontics is still orthodontics. Tracing software. When you learn these courses, when you go to these courses, they will give you people who can help you out. I use the software that came from my course program, but there's different services that are available. Dolphin, if you want to buy a complete service, is what most orthodontists use. Most of the software companies will trace your x-rays for you for a fee for pay as you go, or you can buy a package. Chewing gum, sure. Chewing gum is Li Ping Su asks if we encourage chewing gum. Anything that can improve the tone is good. Hickam reverse pull headgear. The Hickam is getting harder to get hold of. I used to buy them from Great Lakes Orthodontics. You have to hunt them down. So Olivia Ong asks, do we do exercises before there's tongue space? So I have 2 exercise series that I'll be talking about tomorrow. And one is when there's no tongue space, and one set of exercises is when there is tongue space. So everything in its time and place. So the question is, what are some of the problems that can occur? And we'll talk about that in upcoming modules. So this afternoon, and after this Q&A session, we'll be talking about the problems that happen with the components going misbehaving. What happened? How do you manage failures and screw issues? One question was, why doesn't the acrylic cover the premaxilla? My answer is, I'm primarily interested in expansion, and I want to use the primary dentition as the area that I work on. I never cover the premaxilla. It's the design that John Mew created. We use wires on the premaxilla, covering the premaxilla area to help us control the incisors. Question is if they have different shapes in the upper and lower arch, which is normal, what's my sequence of correction? My correction is I usually expand both simultaneously. And the shapes conform to my plates. So Jolene Yang asked, what's the advantage of the Mew Stage 1 over 3D Swartz? all I can say is I like my results when I use a stage 1. I've never used this 3D SWOT, so I wouldn't be able to give you an objective answer to that. If you like the results that you get in a 3D SWOT, then use that. I like the results that John Mew creates, and I therefore use his appliance. It works consistently for me. When do you use the sagittal appliance? Do you use it before 6s erupt? If I've lost space because of a crowding, or mostly because of ectopic eruption and destruction of an E, or a carious extraction of an E, then I'll reopen the space first. Ortho scanners, Anthony Fan suggested that Medit I500 or I700. Yeah, fantastic. What brand of wire cutter? So Dentara makes wire cutters, but you can actually, the heavy wire cutters, you can use anything. Just try them out. Wire cutters are, they just need to cut, and most wire cutters do. When we're cutting heavier gauge wires like we do here, you do need a proper heavy wire cutter. So the hardware stores have wire cutters that work quite well, so it's a matter of checking them out as well as looking at the Dentarum products. So Dentarum screws have been known to have issues as well, and of course I've tried many Dentarum screws and they all have issues. The ones that I find to be good at the moment are the ones which I call the Hyrax click and the skeletal screw. I haven't been happy with any of the others. So yeah, you got to play around. All right. Another question. These are Enrico questions. So
yeah. No, just send. Can I answer that, Simon? Because that's important. A lot of people do that, and it throws everybody off. So great to see you. No, send me a clean scan or clean expect, then put the separators in, because it won't. If you put the separators in, it creates me a problem fitting the bands, and they won't fit. So
we don't use separators. Yeah, in our appliances, we don't
use separators. Yeah. I think he was talking about the expanders, the fixed ones, if I'm not. But in our appliances, you don't need separators. No, absolutely not. But whatever, clean impression, always. Or scan.
Okay.
We've answered some of those too, Simon, already.
Yeah.
Jessica,
what consideration do you give the condyle disc relationship with the temporal mandibular joint when it comes to anterior open bite? So, Courtney, I do a TMD evaluation, and I base my judgment based on my findings. If I find there to be a TMD issue, then we need to resolve that first. All right, so I don't find often for there to be TMD issues in children under the age of 10, which is the bulk of my treatment. Most people who have TMD issues are usually pubertal or older. But yes, if you have a progressively opening TMD, then and you have inflammation that's palpable in the joint area, then you need to refer to a surgeon so they can do CBCT and MRI evaluation of the joint and the disc. So the consideration I give is that it is part of my examination and diagnostic process. So when a patient presents to you later in growth at say 13, will you consider skeletally anchorage maxillary expander to get transverse width rather than removable tooth-borne expander? When I have a person who has stopped in their growth and development, we use TAD expansion, surgically assisted. So one of the things that we will talk about tomorrow is what Roland Barrowman, my surgeon, helps me with. So the answer is yes.
And Simon, just to tell all the panelists that during the week or in the next few weeks, I will be making one of those, and I'll send it to you or Kian, and you can actually send a photo to everybody, the one that we use.
Yeah. And so another question is, if we have to take teeth out, how does it affect facial growth? My answer to you is this. Pulling teeth out doesn't affect facial growth. The posture affects the growth, and retracting to close space affects the growth. So if our goal is to protract and to improve the posture, then we are okay. So being narrow focused in thinking that pulling teeth will cause retraction or pulling teeth will cause poor growth is misguided. What pulling teeth can do is it can set you on a path that makes you retract to close the space. It's that path which affects facial growth. If you can bring the sevens into place without retracting, you're going to have nice facial growth. But if you have to pull the anteriors back to do medium anchorage closure, then you're going to suffer.